Good morning. This is Dr. William Sunstein of NSPC Brain and Spine Surgery, and welcome to our 9th podcast of the Spine Bros.
And I'm Dr. Richard Obedian of Island Spine and Sports.
Wonderful. And we are here today with a very special guest, one of our patients, Mr. Gary Gorski. And we're delighted that you're here, and thank you so much for coming here. We can talk all about your experience that you had while you met us in our offices, and we're basically it led to you having spine surgery with us.
So, sure. Gary, why don't you start by telling us a little bit about yourself?
Okay.
And then what started happening to you and how you finally came to see Dr. Sunstein and me.
Okay.
And then we'll take it from there.
Sure. Thank you for having me.
Oh, absolutely.
Appreciate
that.
And
talk about everything.
You're right. Sure. So this is my first time doing anything like this. So this is very outside my comfort zone. I'm an extreme introvert, but the doctors did such a great job that I feel that I need to come and tell my story.
Well, maybe this is the start of something new for you.
And thank the doctors. So yeah, I'm 47. Well, I'll be 47 in August. I'm not sure I'm rushing that. It's 46 currently. Married, 2 kids. My daughter will be 7 at the end of June, and my son will be 2 at the end of August. So what brought me to the doctors was at the beginning of January, I started to feel this pain down my left leg, and I just thought it was a sciatica issue, and I thought, most people my age getting older have similar issues. So I just kind of, if you will, manned up and just ignored it and just went on my routine. However, it got progressively worse as time went on, and I just still kept ignoring it. And it got to the point where it was a breaking point where I actually said to my wife, I think I need to go to the emergency room. So she talked me out of that. She thought I was overreacting a little bit. We're tough in my house, I guess.
You're an avid athlete. You're a runner.
Yeah, well, so at this point, I wouldn't call myself an athlete, but I try to stay as healthy as possible. So yes, I either go to the gym or I run for a decent length, about 6.5 miles is my normal run.
And that was before your surgery. You were running 6.5 miles.
Yes, 6.5 miles, or going to the gym, lifting fairly heavy weights.
You never had this kind of pain before?
No pain whatsoever.
Were you still able to run when you had this pain going down your leg?
I still did it. I forced myself to do it. Just because I didn't want it to overtake my life, and I work from home. I'm a lawyer. I work from home for a global telecommunication company. So I sit at a desk for 8-9 hours a day, and the cabin fever is a real thing. It sets in. I got dogs that bark and cat that fights with the dog, and everything that goes on with being at home all day. So
not to mention a 2-year-old.
Well, he's in daycare.
And a 7-year-old's not that easy either.
Oh no, she's a diva already. It's a lot of work. So anyway, yeah, I forced myself to go to the gym or go for a run, and this leg issue was really affecting my life in a bad way. I had to be on point for my kids. Everybody's up and out of the house by around 7 o'clock. Kids are up at 6 o'clock. So the pain was getting progressively worse. Like I said, I was going to go to the emergency room. My wife talked me out of that. She said, just go to a walk-in first. I went to a walk-in, and they said, it's just sciatica. They gave me a steroid pack. So I took that, went to a chiropractor, went for massages, did all the traditional things that I thought were right to try to get.
And your cousin's a chiropractor, right?
My uncle's a chiropractor, and his son is a neurologist. Yes. So eventually I called them, and they said, listen, you need to go to an orthopedist. So I didn't know anybody. It was just a hassle. I'm like, this is, who wants to go to doctors, right? No offense, but nobody wants to go to doctors.
No, you have enough on your plate.
It's usually never good news, right? So I went to another local place. I don't need to name who it was. They eventually sent me for an MRI, and I went for the results. And the doctor instantly said, no wonder why you're in so much pain. You have a huge synovial cyst crushing your sciatica nerve, and you need surgery. Just like that. So I went from thinking I just had a small issue to...
He didn't offer you any other options for the treatment of this?
I said, can we do an injection? Can we try to suck it out? Whatever the case may be. And he said, in my experience, one this large, you cannot, and it's not a pure liquid, it's more of like a gel substance.
This guy was actually pretty much right on with, I obviously, we always try to treat people conservatively for a while, and This was a relatively short period of time. But he at least he did the right steps to get you going.
Right.
At least he got the MRI.
Yeah,
yeah,
MRI
right.
was,
but we see people with synovial cysts a lot. And I usually don't recommend surgery immediately unless they're
No, we usually
neurological deficit or.
Well, I was in severe pain. So the pain was almost. I mean, from a scale of 1 to 10, I mean, it was constantly at a 6, and in the mornings it was a 9. I mean, it was unbearable.
What made it worse? What was the worst?
I think just waking up from whatever sleep I got in the morning, trying to get out of bed just to get the blood flowing. I mean, it was a 9, like brutal.
You had tried the Medrol dose pack. Did they give you any other kind of medications? Like
No, just a steroid pack.
steroid pack.
Did it help you? Did it make it better for at least temporarily?
And also he gave me Lyrica, I believe.
Lyrica.
I believe, yes.
Which is an anti-pain medication that
Nerve. I think he said it was for
it
the
helps
nerves.
nerve pain.
Right, right. So,
Yeah.
but nothing.
It's a cousin of Neurontin.
It was just a Band-Aid. Nothing was a real relief. So again, extreme pain, significant loss of mobility. I had no range of motion, and I basically felt like it was a dead weight. I was just dragging around my leg. Right.
Left
So,
Every day you had this pain.
every day, all day, all day.
And nothing at all on the right side.
Nothing at all. On
Did
the
you have
right
back
side.
pain at all or anything like
Nothing. I mean, it would start just kind of up here in my left hip area and it'd go all the way down, radiate through my knee into my ankle. I was just dragging dead weight.
Did you feel like you had any weakness? Or anything
Yes, that was a significant loss of strength.
Loss
yes.
of strength in that particular leg.
In my left leg. Like I said, I felt like I was eventually dragging my left leg around. It was just
almost
dead
like
weight.
a drop foot.
Yeah, it was like dead weight. I was just dragging it.
I mean, we'll talk about what he had and everything, the pathology of this type of
Right.
degenerative condition. But this really, this course of the way it affected you was pretty rapid, considering it's been there for a while.
And all this time I was still going to the gym and still running. And it's funny, it's ironic. The beginning of the runs would be brutal where it was torture. But by about 2-3 miles in, it would loosen up and I'd feel absolutely great. I'd get home from the run and my leg would feel great. But a few hours later, it would
Back.
come back with a vengeance.
Do you think it's from that endorphin high that runners get that the pain goes
absolutely.
away?
Yeah,
Absolutely.
It's a real thing.
That makes sense.
100%.
Real thing
100%.
that
100%.
It was great that you were able to get to that point of the run to be able to get
Yes.
the endorphin high.
Right,
actually, with that synovial cyst.
Yes, that was the mindset trying to get there. So yes, so anyway, I was all ready to book surgery with this doctor who first advised of the synovial cysts, and I called my uncle, who you guys are aware of, and he recommended Dr. Sonstein. So he's the first doctor I called. You saw me within a couple of days. I think I called you like a Thursday or Friday. You saw me on a Tuesday, I believe it was.
Interesting how they always think of the orthopedist to see for the spine problem.
Right. So, right. So,
okay.
so
That's okay.
yeah, so my wife and I went to go see you. You confirmed what the previous doctor said, and I said I need surgery ASAP, like tomorrow. And you were going on vacation, so you said you're gonna have to wait 2 weeks. I said, okay. You gave me some more medication to help with the pain, and I waited 2 weeks. Oh no, I'm sorry. The same day you sent me to see Dr. Obedian.
Same day.
Right away. Instantly.
We have a team approach.
Yes.
Yeah.
So I mean, instantly I went
you
from
had
your
them-
office to Dr. Obedian's office, and your offices both are great, and you confirmed what needed to be done.
Yeah, and by the time I saw you, your foot was numb and weak.
I wasn't.
And it completely correlated with what the MRI showed, which was this, as Dr. Sonstein said, a very rather large synovial cyst. You also had a subtle L4-5, and the cyst was at the L4-5 level, and it was also causing some instability in your back. You had a little subtle grade 1 spondylolisthesis.
Why don't we look at the imaging, and we can actually go right to the
Let's go to the videotape.
pictures worth 1,000 words.
Yeah, I was completely miserable, completely.
Miserable, man.
And I had 2 little kids at home, and I couldn't afford to be miserable.
Were they aware of what you were?
They
going
knew
through?
that my leg was hurt. My son was, he was 1.5 at the time. He was oblivious to
wasn't-
everything. But my
All he
daughter,
knows is no.
right? But my daughter was very aware. Yes.
Daddy wasn't doing all the things like he usually does with me.
Right.
So you see here, this is what we call a sagittal or side view of the spine, and you can see. We don't have a pointer here. Do we ever?
I have my finger.
Well, you go ahead. You point out the
So,
important things.
This is the sacrum. This is and there are 5 lumbar vertebrae. This is L5, L4, L3, L2, and L1. And in between the vertebral bodies are the discs. And the way we number the disc is between the L4 and L5 levels, the L4-5 disc. Now, what's interesting is that in this canal, the spinal canal, you see this structure that looks like it's fluid filled, and it's occupying a large portion of that of the canal, and that's the synovial cyst.
And also, just everyone, the audience should understand that this is not where the spinal cord is. The spinal cord ends at L1, which is up above. So this is a sac of nerves, and the white is fluid inside the canal. And the gray things, these little stringy-like things, are the nerves, and that dark thing with some light areas. So there's some cystic. These things can be complex, and they're not like balloons where they're filled with fluid. They're oftentimes jelly or grungy material, and there can be some fluid, and that's why there's lighter areas, which represents fluid, but there's also darker areas, which probably represents necrotic degenerative material.
Right, and this cut is not directly in the center; it's more on the left side,
right,
which is where his cyst was. And that's why he only had unilateral leg symptoms, only on the left side.
So the thing is, cysts. The body loves to form cysts. We can get cysts all over the body,
right.
And for some reason, the body makes cysts, all over, but they also can form in the spine, off usually the joint that is in the back.
Facet joint.
Now, why does that happen? Why does a cyst form in the joint? You think about it. My theory is that because the joints degenerate, they get arthritis, they lose their lining, that the joints become a little bit misaligned, not in the right, orientation. And perhaps maybe some of that lining starts, is pooching outward and starts a process of formation of this degenerative thing. Also in the morning, we'll show another interesting cut of this. You're laying down all night long. The arthritis, the joints and these structures tend to fill up more. So that's why you get more pain sometimes in the morning.
Makes sense.
Yeah, and so this is an axial cut of the spine at the L4-5 level, and you can see this is the front of his body. This is the back of his spine. This is where the disc would be. This is the spinal canal, and this structure over here on the left side is the synovial cyst, and you can see that it's emanating from the facet joint over here. It probably it came from there. Do
you think it's scalloping the posterior aspect of the vertebral body? You think there's actually some erosion of the bone from it being there for so long?
That's what it looks like, doesn't it?
Yeah, like the little area looks like there's actually a concavity within the bone, which sometimes happens with long-standing
pressure
masses.
That can happen. It's like a rock that has a constant drip of water over it starts to change its shape a little bit, and the same thing can happen to the bone in response to stress. It changes in response to stress.
Can we have the next cut?
And there you can see.
There you really see it
much more clearly coming off the facet joint. This is the facet joint over here, and that's the cyst that's been forming, and it's really crushing the left side of nerve. The nerve root comes out here.
And also,
and you should come out over here, and you really don't see anything similar to that on the left side.
It's also
his left side's completely crushed,
and it's affecting the nerve that's descending as well to the next level below.
Right. So it's affecting both the L4 and the L5 nerve. Usually, typically when you have a herniated disc at the L4-5 level, typically you would get an L5 kind of a syndrome. If it's a far lateral disc, you can get an L4 syndrome too. But in your case, your cyst is so large. And it's actually crushing both nerves.
Right, and you also had some weakness of if I recall, you had weakness
dorsiflexion and EHL.
Your foot movement, right, and your EHL. So EHL is usually
L5.
purely 5, and then L4 is more prominent, nerve supply to the for L4. Yeah, at the dorsal
tibialis anterior.
Tibialis anterior. Right. Yes.
So it's a significant problem, and with with the pain, the numbness, the weakness, surgery is definitely
indicated.
Is indicated. Occasionally I've had patients who have asked, "Is there any way you can pop that thing?" and so they're really resistant to having an operation, and they want to go for it.
Many have tried.
Some pain specialists have tried to actually put a needle into that cyst and just pop it.
Right.
And by popping it, you don't even need to really aspirate. By popping, you can decompress it, and maybe like a balloon, it will shrink. Oftentimes, it's unsuccessful.
I was going to ask what the success rate is.
Yeah, it's
low,
and the cyst can recur, it's somebody who has neurological deficit like you did, who has significant numbness and weakness, intractable pain. It's not really recommended either. But in somebody who just has maybe some pain, it's milder pain, and they really don't want to go for an hernia operation, you can try popping that cyst, and rarely it's effective.
What about an epidural? What about like a steroid injection? Did anybody offer you that kind of thing, or did I even?
No, neither of you guys did.
You were miserable.
Yeah, yes.
You can consider an epidural steroid injection,
but again, you're masking.
I think everybody I spoke with said it's beyond.
And you had weakness, which to me is an indication for the surgery, because you don't want to play around with your foot flexor, because once that goes, you have a slapping gait, and we don't want you to get that.
No, because once you get that deficit, it can become permanent.
Exactly.
And we do the operation so it doesn't get any worse, and that and there's no guarantee that your numbness and weakness will get better even with a successful operation. But what you had going for you is that you're young, you're healthy, you're athletic, you have a good blood supply, you're not diabetic, and so we ended up deciding to do the operation.
Yes.
Dr. Sonstein came back from his vacation.
Where was I?
You went somewhere with your daughter, if I recall correctly.
Did you go skiing?
Oh, yeah.
I think he went to the Alps.
Sweet.
Nice.
Well,
that's nice.
It's one of those bucket list things I wanted to do.
Very nice.
Hopefully you'll get to do it again.
Yeah.
That's an amazing place to go. So
Well, we went.
I used to. My parents had a house at Hunter Mountain, so I went every weekend.
Oh, nice.
For
nice.
about 10,
That's
15
where I
years.
learned how to ski.
Yes, we could actually ski to the door from the mountain.
That's the ideal situation.
Yes, it was fantastic.
Do you still have it? You don't have the house anymore?
No, they sold it a while back. Yeah, once I got into college and
that was the end
life
of that.
goes on. Yeah.
Do you still ski?
I here and there. It's been a while. I want to get my kids on skis.
Oh yeah, that's the best when you get them.
yeah.
Which is a good place to learn.
Yes.
It's not too far away.
Different type of learning. You got to learn how to dodge people and ski on ice.
Yeah,
as opposed to
it's
going
very-
out
you're
west.
gonna have to
or
go to
the Alps.
Vermont maybe.
Yeah.
Skiing on ice is quite a challenge.
Yeah. Right.
There's nothing better than skiing with your kid. It's like
And
the
there's
most
nothing better
thrilling
than
thing.
skiing in the Alps where you went.
Yes, that is one of the things.
That is one of the bucket list things to do.
But recently there were some bad things going on in the Alps with the glacier.
Oh.
Anyway, that's beyond our
Let's
discussion.
move on from that. So anyway, we took you to the operating. It was about 3 months ago. I think it was February
25th, exactly. It was a Tuesday.
right.
February 25th. And what did we
Tuesday.
say to you about your surgery? Like, I mean, we you had questions, and you had that little slip of the bone, so we had to offer you also, in addition, fusion.
Yeah, so it's probably worth noting that I was very nervous going into the surgery because my father had back surgery for a different issue. Don't ask me because I don't want to misquote it, but long story short, his surgery did not go well. He had a CSF leak, if I'm saying that correctly.
Yep.
We don't like
A
those.
cerebrospinal fluid leak. It can happen during an operation.
Yeah, I mean, multiple surgeries to try to fix it. He had to go to different doctors.
It's a really bad headache you get.
In and out of the emergency room with severe pain. And he went from running marathons to not be able to run at all.
Yeah, that's a scary thing.
So I can understand why you're totally.
And this happened to him when he was
scared.
about 65. And I was 46 having surgery. So I was completely bugging out. I was very nervous that I was going to wake up and be a shell of myself, kind of like, unfortunately, how my father ended up. However, I woke up and my leg was instantly better. I felt amazing.
We did it. I think we did it at Winthrop or NYU.
Yes,
Lango,
at
Long
Winthrop.
Island.
It was Winthrop. Like I said, I woke up, my leg pain was instantly gone. So the first thing I said was, thank God. They wanted me to get up and moving around. I did with no problem. I was going up and down steps.
They got you up that night, didn't they?
Within a few hours. Within a few hours. And I walked out of the hospital with a backpack on, carrying my laptop in 48 hours.
How long were you? So you were there for
48
only
hours.
48 hours. That's actually pretty darn good.
I think you guys wanted me to stay until the drains came out or something along those lines, but my drains fell out, both of them.
How convenient.
So
It happens.
I was out of there.
The plastic surgeon doesn't like to sew them in for
Right.
various reasons.
Well, people sometimes forget that it's sewed in and they yank
it out. Yeah. So
It's
what's
a
this
very
thing?
painful
Yeah.
Please.
Right. So then,
And what the operation we actually did was, I think we did a hemilaminectomy. We only did it on one
This
side.
was I remember the cyst. The thing about these cysts, they're fascinating because people are, after the surgery, the first thing that somebody says is, "Did you get the cyst? Did you get the cyst?"
Right.
That's all they care about. Did you get the cyst? And it's not cancer. It is a benign structure. It is an expression, I say, of arthritis. That's really what it is. It's just another expression. And these things are particularly nasty because they always come from behind. And they can affect the sensory part of the nerve, and they're very, as you experience, very, very painful things, and
But he's right. They never become cancerous. They're not a pre-cancer.
They're not
When I first heard the word tumor, that was first thought.
It is a mass, but it is a benign mass. And the thing about these things is that they're every time you do one of these things, it's never the same. So your situation, I recall, you had like this. The cyst was not well defined when we went in there. It wasn't like a ball. And there was a lot of degenerative necrotic material that was filling the side of the canal where the nerve was. And the important thing about this type of surgery is you must find the nerve. And once you find the nerve, then you can separate that from the cyst. And sometimes it's not that clear. And the main sac, where the nerve is like a trunk, the sac is like a trunk and the nerve is like a branch. You want to see that main trunk, and sometimes that cyst is stuck to that main trunk. And the caveat of that is you don't have to get not 100% of it to yield an effect to the patient. Correct. You can leave some of it, so you can leave some of the wall, because otherwise you fear you're going to get a leak.
Well, think about it. If you can successfully treat a cyst with an interventional radiologist or a pain specialist popping it, he's not really removing the cyst at all.
No,
he's just decompressing the canal.
Right, exactly.
And so Dr. Sonstein's absolutely 100% correct. You can get into trouble if you try to remove every little aspect of that cyst, because the cyst can be very adherent to the dura. Right. And if you pull it too hard, you can get a CSF leak. And that can be a disease.
And that's all we needed to tell you right after your surgery.
Yeah, you advised of that, and I was, again, because of my father, I was very nervous. Yes.
Yeah,
and then you also told me that you had to remove 2 vertebrae and infuse them back together, so I was very nervous.
Well, because the cyst arises from that facet joint, and you had some subtle instability on the plain X-ray, you got to remove some of that facet joint.
Right.
And if you remove more than half the facet joint, you render it theoretically unstable.
And you're a young person.
And you're a young person. You're very active. You're running. You're lifting weights. You got 2 young kids you're chasing around. You want to go to Disney World. You want to have a normal life.
But explain how we made a compromise in terms of fusion, because that's one of the things that we, I think, like to do. Is everybody thinks of fusion, they think they're going to get hardware. Before they had
always
hardware,
necessary to get hardware.
You don't have to have hardware, because before they had hardware, they did fusions all the time with just bone graft material, and that's what we use. We call it bone dust, and
it's your own bone.
But it's your own bone.
So in order to do the procedure, we remove a portion of the lamina. So it's called a hemilaminectomy. We just remove the half.
You got to get access to that canal.
This is the lamina over here. Mm-hmm. Okay. So we unroof this. We remove that portion. We leave the right side intact. And we start to look for the cyst and the underlying nerve, which is exactly what you don't want to injure. So you got to be very careful and be very cognizant of that. And then you can sort of piecemeal it away. You don't try to scoop it out in one bite and take the entire thing out, because that's where you can.
Sometimes you get lucky and the thing comes right out.
If it pops out like a baby, that's fine. But it doesn't always come out that way, and you don't force it.
Right.
Like he said, every cyst has a different personality.
But the key is you want to get that nerve decompressed. And the way to do that also is, besides the cyst getting that mass effect, you want to unroof the tunnel that the nerve goes through at the same time. So the nerve is really, really
into
free.
The foramen.
And you want to follow it down till it's totally free and you're satisfied.
And you open up this foramen as well.
Then the nerve is always down at the bottom in your exposure, because that comes from above it.
Yeah. So
that's how you know where the nerve is going to be. So you don't.
Correct. And then that bone that we remove from the lamina, that's what we basically put that in the in an orthopedic type of a blender that separates soft tissue from the bone. It's literally what it is—a very expensive blender.
Yeah,
we add. In your case, we added something called BMP. BMP is a hormone called bone morphogenetic protein.
Okay.
And it is the hormone that your body makes when you break a bone it's a signal for your bones to heal.
Interesting.
And the same technology that gets your bone to heal, your body to heal a fracture, is what we use to trick your body into fusing. So fusion is almost like a fracture that's healing. So there are different tricks that we use, and one of them is the bone morphogenetic protein. Sometimes we'll use a bone stimulator as well, which is an electronic device you can put around your waist.
You gave me one.
And get yes. that, and add that to the armamentarium. hardware is sometimes used in somebody who's very unstable, and studies have shown that people who have hardware may fuse at a better rate, but it's not required.
People are very nervous about the idea of fusion. It's not nuclear fusion. People think it's like they're going to explode. It's not that at all. All we're doing is giving you stability so that you don't have a recurrence, because the reason why this is happening is there's some abnormal motion going on because of some degeneration.
Right.
So the body is basically, because of the center of gravity, the spine, it tends to slip forward. When that happens, the spine is signaled to make something to auto-stabilize itself. And in some reason, that cyst is an expression of that spine's chance to try to auto-stabilize itself, but it does it in a way that hurts you.
What probably happened is that you had an injury to the facet joint.
Okay.
That facet joint reacted by, your joints, all of your joints in your body make synovial fluid. Okay. And that facet joint must have been disrupted in a way, and just synovial fluid, instead of staying within the joint, started pooching out.
Right, that synovium pooched out.
And the synovium pooched out because there was a subtle injury to that facet joint. Maybe you twisted funny or something happened to your back at some point. And then that cyst started to form over time. And it could have been years that it may have formed. It could have popped on its own, then it got better.
You never had a prior MRI, so we couldn't prove that it wasn't there before.
It's something that was there for a while, and it got to the point that it got so large that now it was crushing your story of being a tough guy, like running through the pain and going 6.5 miles every other day, and even though it was painful, you were still able to do that. You probably had you ignored a lot of the symptoms you may have had for a while, and that's why it got to that point that it was so large that it became operative, because it reached the point of no return.
Exactly right. Yes.
I would do the same thing. I'd be like, I have pain right now in my buttock.
Right.
I mean, I've had it for a long time. Should I get an MRI? Maybe so.
Well, we can talk about that. When should you get an MRI when you have back pain?
Right.
There are certain red flags that if you're over a certain age, that we worry about cancer. If you're over the age of 50, 55, it's warranted. If you have pain that wakes you up when you're sleeping.
Yeah, that's the one thing. Did that wake you up when you were sleeping?
Oh, yeah.
So there you go.
I wasn't sleeping really well at all.
In medical school,
couldn't find a position that was comfortable.
Nothing was comfortable. It was comfortable to sit. It was comfortable to stand. It was comfortable to lay. Any one position for too long was uncomfortable.
It's like cancer until proven otherwise. Pain at rest. If you had a trauma, if you had a major fall and you get this horrible pain and nothing's helping you, that's an indication to get more imaging.
Right.
If you're having bowel and bladder symptoms. Now, your bowel and bladder were okay.
Yeah, I was fine.
You didn't have this. There's a syndrome called cauda equina syndrome.
Okay.
If you have any symptoms like that, you can't wait on that. You got to get an MRI right away.
Right.
To make sure there's no compression of the cauda equina. But thank God you didn't have that. So we did the operation.
Right.
We ended up doing a limited laminectomy. We try to preserve as much of the joint on the other side as possible. And
we did it a small in situ fusion at L45.
In situ fusion without metal.
No metal, and that's it. And then we had a plastic surgeon close your wound. You had a couple drains. That's standard.
Yep.
And you felt immediate relief, and
and your numbness and weakness also got better. Did it get better right away?
I woke up instantly better.
And you got out of the hospital, hightailed it out of there in 48 hours.
Yep. I wanted to go home and get out of there. And my whole goal was just to get back to running and back to the gym and back to normal life.
So since the surgery, tell us about what's going on with you.
Right. So I didn't do anything for 2 weeks for the first follow up. Then you asked me to come back in another month. So again, I didn't do anything. So 6 weeks I took completely off. Then you gave me the green light, and from that. The next day, I just started getting back to where I was before surgery. Yeah. And I've had no issues, no pain other than soreness and achiness. But that also comes with just trying to get back into shape. The muscle atrophy was severe. But I couldn't have been happier with how the surgery
went. You have an
went.
Excellent mental attitude.
I try, yes.
Somebody who is able to still run 6 miles with this kind of a situation is mentally tough.
Right. Well, yeah, I tried to be, yes. I was trying to have a good attitude on it. I didn't want to be a victim. It was just some bad luck, and we all faced with challenges, and I just wanted to overcome.
How do you explain that mental toughness? Because it's hard to find this generation.
Yeah, most people are weak. So it's funny. I just saw Dr. Obedian yesterday for another scheduled follow-up, and you were asking me about running and what I listen to. And I don't listen to music. What I listen to, and it's not for everybody, is David Goggins. And Yeah, I want to be clear. I'm not even 1% of what he is or what he
He's
does.
a phenomenal human being.
He's not for everybody. He is.
What is he for our audience? Tell us about him.
So I guess he started out as a Navy SEAL. He's an Army Ranger, endurance. Not endurance, an ultra athlete. You know, he runs 240 miles.
He's got an amazing story.
Without stopping. So I mean, we could speak for hours on all his accomplishments.
He was an African American kid who was kind of abused by his father.
He was beat by his father. You know, he
was dyslexic, had learning disabilities.
All types of learning disabilities, severely overweight, couldn't swim, was a loser. He calls himself a loser in life. So basically everything going wrong for him. And one day he just decided to change his mindset and basically go for it. He went to the Navy SEALs. He tried out for the Navy SEALs without being able to swim. Overcame all that.
That could be a problem.
Yeah. You know, he went through 3 hell weeks because he refused to quit. But I think the first one he had double pneumonia, so the Navy set him back. So he went back in again. He got through hell week with a broken knee, but he couldn't complete the rest of the training, so they sent him back again. And he went back for a 3rd time. I mean, most people quit healthy, tap out after a few days. He
did it 3 times in 1 year.
3 times in 1 year.
Yeah.
Got through it. He would duct tape his legs up in the morning, you know, to run 6 miles every morning, 4 o'clock in the morning, you know. So, you know, he got through that and then just kept looking for more and more and more. So, you know, again, ultra marathons.
There's ultra marathons. They run over 100 miles.
Right. So
That's a pretty substantial amount of.
Right. He ran 100 miles without training at all. And he was a power lifter at this time as a Navy SEAL, weighing about 250 pounds. And ran 100 miles without any training in 19 hours. And he was basically, if you were listening to it, I'm summing it up now, he's basically a step away from dying in the effort that he put in. Literally a step away from dying, but he completed
urinating blood. And
he finished.
That's not a good thing.
Broke every bone in his feet, whatever the case may be.
Stress fractures.
And he says in that 19 hours, he learned that the human mind, body, and spirit, when come together, can accomplish things that nobody ever thought was possible.
Wow, that's very inspiring for you.
So I'm just...
Your recovery, you know?
Right. So
It's for everybody. It's for everybody.
He's not for everybody.
But it's great.
Yes.
He's got some salty language, but
it's very raw. It's in your face.
Salty language is
like a
liberal use of the F word.
Yes.
Okay. All right.
But that's a time frame. You know, he was born in 75, so he's 3 years older than me. I can relate to him. You know, all these other motivational speakers will kind of just...
And he uses his setbacks as a motivation for
Right.
himself.
Yes, he faces all his issues and
he dealt with racism. He dealt with a lot of abuse. He dealt with
absolutely so
a lot of problems.
I credit him to helping me find more of myself and changing my mindset. And this is what helped me get through this and get back to where I needed to be.
And so when you went back to running,
yes.
Did you go back to 6 miles immediately, or did you kind of?
No, I wanted to. But no, I listened to your advice, and I think you literally said to me, "No pain, no gain" is not your mantra right now.
That's right, because you can actually go backwards in some ways.
Right.
Because people start feeling good because they had a successful decompression.
Right.
Still want to heal from your operation.
So this was an injury. This is not just pain. I was actually injured, right? So I took it slow. So I lighter weights in the gym, and then I just started on a treadmill. I think my first one was 4 miles on a treadmill.
Did you start walking first?
No, I just stopped right out of the gate. I
went
ran.
right out of the gate running. Interesting.
4 miles. Felt great.
And how fast after your surgery did you start that?
6 weeks.
6 weeks. The day after he saw me at 6 weeks, he's
So
like, all right,
the next day,
that's important because a lot of people ask, when can I go back to do this? When can I go back to my job? When can I go back to lifting? When can I go back to golf?
Well, I only took
all
a
these
week off
questions.
from work because I work from home, so it was no big deal. So
Right,
work
so
was not an issue for me whatsoever.
and you weren't taking much in the way of pain medication.
I think the initial dose you gave me, and then because that's I don't need to get addicted to that, and then it's just another thing to deal with. I just wanted to get back to my normal life.
Sure.
And so I started off 4 miles, and the next run was 5 miles on the treadmill, and then the next run was 6 miles on the treadmill, and then the subsequent follow-up 2 or 3 months in, whatever it was, I asked if I could run on the road, and you said yes, and my normal route is 6.5 miles, and here I am. I ran it yesterday before I saw you. I went to the gym this morning before I came in here today, and I'm back to living.
That's remarkable.
Back to normal.
I'm back to living.
I mean, not every course is like this. I mean, this is...
Well, it's mindset.
This is
90%
great.
mindset.
I think that's true of life.
It's very inspirational to our audience, because it shows that you can, if you have a good operation, you have a successful outcome, you can get back to doing all this stuff.
Well, one thing I learned in spinal fellowship was, a lot of the success of spine surgery is choosing the right patient.
Right.
Because you can have the same pathology in two different people. You do the same exact operation, and one person will have an amazing outcome, and one person not as good.
Why do you think that person is not going to have as good an outcome?
And
same MRI.
And I think it comes down to mental health.
100%.
A lot of the time,
That's
what you're
one
able
thing
to
I've
put up
learned.
with.
Yes. We all have bad luck. We
how-
all face adversity, and this is the definition of bad luck. Who wants to wake up and deal with this? You got to get your back. I mean, I have a scar like this on my back. I didn't.
It's how you see the world.
Right.
You see the world. The cup is half empty or half full.
Exactly.
And if you have a more optimistic attitude, I think those people tend to do better. Even in our training, in going from college to medical school to internship, residency, fellowship,
You could find
there's a lot of hardship.
You could find a lesson in everything, though. I want to see how it stack up after this. If I could get back on my feet, see what kind of man
you're already doing incredibly well.
It helps before being in good shape before this type of surgery.
Well, of course, yeah. I mean,
that
if I
really
was,
helps.
But you're resilient. You're resilient. You came
right.
back, and I'm sure it's not easy for you to run 6.5 miles.
We were laughing yesterday. I hate running more than anything in this world.
you
That's
force
why
yourself
I
to
do
do
it.
it.
It's a painful
Discipline.
kind of thing.
It hurts. It hurts my soul, as we said yesterday. It literally hurts my soul, but I do it because it builds mental toughness and it's good for me mentally, and it's discipline.
Yeah, no, I think it's a great thing if you can do it. It's wonderful. At least definitely do some form of regular exercise.
Right.
The thing about this MRI, one of the things about selecting patients is that you want to make sure that the MRI correlates with the symptoms of the patients. This thing is on the left. It's in the L4-5 distribution. Your pain was in an L4-5 distribution.
matched perfectly.
That's the best setup for success. There's never a 100% guarantee. When you do the surgery, you don't know how the nerve sometimes is going to react. Sometimes people with long-standing compression, even though you relieve the compression, they may not bounce back as fast. But you had a relatively short course, and I think that helps as well.
Right. Yes. Thank God.
Yeah.
So, I mean, in terms of people always ask about what are my limitations after surgery. What did you feel like your main limitations were after this type of surgery? If you had any.
I mean, there really weren't any. Immediately, it was just being able to pick up my kids.
And you were able to do that.
Or I mean, within.
You had to do that. You have no choice.
I think I had physical therapy come to my house twice, and now the guy was, I don't even know why I'm here.
Yeah.
He's like, can you go up your steps? I'm like, I carried both my kids going up the steps.
There you go.
This recovery is a little bit different than somebody who has a herniated disc.
Right.
Because a herniated disc, we worry more about getting a recurrent disc herniation. So we really limit those patients a little more than somebody who has a synovial cyst.
This thing doesn't come back the next day.
No.
Right.
And if you do it right, I mean, the chances are of this thing ever recurring is practically nil because you're due to fusion because
you also did a laminectomy over that area.
And you've given yourself a lot of room. What I mean? Now you have room, and that
your
canal.
nerve is wide open.
So there's a lot of factors.
I feel great. I do. I feel great.
Well, that is just absolutely wonderful. We love music to our ears. We love hearing that.
Yeah, like I said, this is outside my comfort zone, but I feel necessary to come in and say how much of a great job you guys did. I was very nervous.
Thank you.
I didn't think I was going to be able to do anything near what I was able to do beforehand because of my father's situation and my prior experience trying to help him get back on his feet, and it's just.
Well, I think a lot of this
I
thing
couldn't
is
be
also
happier.
It's genetic. I mean, also people get with parents who have degenerative disease who have had surgery. They also follow suit with their spine as well. So we see that a lot.
Yeah, I mean medicine. I mean a lot of problems in medicine are hereditary or and have some genetic component as well as a.
Thank God for modern
component.
science is what I tell my wife and all my friends because I mean even 50, 30 years ago I would have been screwed, right? I mean.
It's funny. I mean, they were doing stuff like this, believe it or not.
Okay.
We really haven't reinvented the wheel so much, actually, in terms of the keys. Everybody's always worried about this and that, but the most important thing is getting a really good decompression of that nerve from that cyst, and that's pretty much
right. The basic
going on for a
principles are
while.
still the same. What's changed, though, from 50 years ago
is the materials.
that the technology has gotten better.
And that blender.
50 years ago, there wasn't really MRIs widespread.
And there wasn't a blender.
People were getting
like that.
People would get a CT myelogram.
Right.
which is a CAT scan with dye, and there were problems with the dye. People would get reactions to the dye, and they would have arachnoiditis or other types of problems from those, just the injections themselves. They would get headaches from the injection through the CSF into the canal, and there wasn't BMP. There wasn't all the tools that we now have at our disposal to make the fusion part easier. And
I think I'm sorry, but I think if I recall correctly, there was another, I don't know if he was a doctor or a technician who had some machines set up to all my nerves.
Right. So that was very important because
so, I mean, that's got to be advanced.
That's neuromonitoring.
That's neurological, and that's kind of standard of care now in Long Island to perform these kind of surgeries with neurological monitoring.
We didn't have that when I was a resident. We really only specifically used that for like neck,
spinal cord,
right,
neck or
thoracic
cases,
and that would give you an alarm if something was twinging or something.
Exactly, they tell us how the nerve is, and it basically allows us to do what we're doing more safely.
Well, what it does is in real time, it can tell us if there's any kind of nerve root compression based on you can't tell us because you're sleeping.
Yeah.
Okay. But if for example, even not from your spine, if you're in a certain position and the nerve, like your perineal nerve around your knee is being compressed by a pad that's misplaced.
Gotcha.
And your leg is going numb. The nerve or even your upper extremities.
Right.
You're kind of lying on your stomach and your elbows are bent 50-50,
Yes.
and is there pressure on your ulnar nerve that's going to give you weakness or numbness in your pinky and your ring finger? They will tell us, I'm getting some abnormal signal in the hand.
May I direct you to our previous podcast?
Yeah,
on
we did it. We had a podcast just specifically
on neuromonitoring. We talked about that.
Interesting.
But it can prevent some complications that really should never occur when you do spine surgery. And we found it to be really helpful as far as that goes. I mean, rarely do we see much of a change intraoperatively when we're sometimes rarely we'll see some improvement after a decompression.
No,
takes
rarely
place.
did they say, "Oh wow, look at this, this graph now is so much better."
We're a little saddened by that. It's like, oh look, it's so much better.
Every so often it happened, but we have in the room we have a neurophysiologist, a person who's been very well trained to monitor you, and then we have a neurologist off site who's in real time making sure what that technician is doing is correct, and they interact with each other about certain things that occur during the surgery.
And it's helpful when the screws are being placed in the lower back. We can test each screw to make sure that it's not irritating any nerve.
Right.
But you didn't need that. So
but you didn't really have that.
So we do that on all our cases. We have monitoring. And
it's a nice thing to have, and you're right. 50 years ago, they weren't doing these surgeries with neurological monitoring.
You're right. Yeah, I felt very confident with the team going in. Yes,
and there are now advances also in the cautery type of equipment that we use to minimize bleeding.
There's a lot of new tools that have helped, but still the basic thing. The art of the surgery is to get that nerve decompressed,
and that's been the same. A good spine surgeon 50 years ago would have done pretty much what we did. It might be a little bit of a different technique, but the basic principles are the same. That hasn't changed.
Some of another thing we have also available to us is these great hemostatic agents. These agents that help stop bleeding. Like when you go in there and you remove a mass that's compressing that area, there are blood vessels that are being compressed. So when you release that pressure, the veins in there, they can bleed a lot. So we have these things that can stop bleeding. These powders actually that help that we didn't have many.
There are different hemostatic agents that we use, and there's also different types of glue. Almost, it's like a fibrant sealant that we can apply to that area it's safe for the dura, and you can apply that over that area. And it helps to minimize epidural bleeding as well. And it can also, if there's an undetected CSF leak, which is rare, that will kind of
that can happen because you have you remove the pressure on the sac, and now the sac's now going to pulsate better.
Right.
And that fluid is inside there. So if there's something there, it's a weakened area. Maybe it won't manifest itself for a week or so afterward. While you're walking around. So that's kind of rare, but that's why we ensure not only the hemostasis, but also we put down that sealant to protect you from that. Which
makes sense.
And then plus you had a drain. So
two drains.
Two drains, a superficial and a deep.
Which fell out.
Well, I was moving around. I was antsy. That was on me. Yeah, I was.
It's all right. We didn't penalize you. We didn't make you stay an extra day
did it on purpose. Yeah.
No, that's okay.
Even though the wound is, it's big enough for us to do the work. It healed up nicely for you.
Yeah, I'm fine. It's there. No big deal. It is what it is.
The incision size is overrated. If you have, I remember when I was a fellow, we had one surgeon who would do very small incisions, and the scar would be very thickened and kind of ugly.
Right.
We had another surgeon who would make a healthy size incision.
Right.
And I remember asking him, I said, why don't you make a smaller incision? He goes, do you think that incision side really makes a difference? It makes no difference. You got to be able to see what you're doing and do it safely.
Right.
That's the whole thing.
Well, you guys explained that to me beforehand. Listen, we're going to have to take, decent sized incision to get to the vertebrae.
You want to see what you're doing.
You want to be able to do it safely.
You guys gave me a heads up. It was
and your incision, the plastic surgeon did a fantastic job. It's just a very thin line.
Yeah,
it's not noticeable. You'll be.
I'm a guy.
You're able to go to the beach.
Yeah,
it's a badge of honor.
At this point in my life,
badge of honor. It's a cocktail party.
I have imagine one in the front. I had another surgery, which is a different story. I'm not creative enough to think of a tattoo to kind of connect it.
That goes from the front to the back.
The front to the back. Yeah,
snake.
But
sometimes we have to make an incision right through a tattoo.
Right.
But they come out pretty well actually after this plastic surgeon closes them.
Sometimes I remember one time I had a patient who decided to get a tattoo before the operation, and when I'd seen her, a month earlier, there was no tattoo. I said, "You couldn't wait until after the operation? What was the rush?"
Yeah.
So we had to cut through her tattoo.
Oh, jeez.
But again, the plastic surgeon did a fantastic job, and she didn't even need to revise it. It worked out well.
Yep.
So So the important thing is we did send the cyst off to pathology, which we always do.
Right.
And it was a completely benign
Thank God.
synovial cyst, nothing to worry about. You really, at this point, at 3 months, you should be able to go back to all of your normal activities.
I have been.
You should.
Yeah. I don't do anything. There's no limitations at this point in my life.
Yeah, where there was riding a bike, swinging a golf club, going skiing, water skiing, swimming. I think one of the exercises I like people to do early is swimming.
Oh yeah, I mean absolutely.
Once there's less pressure on your back, and now the weather's good in the summertime.
If you can get access to a pool.
Listen, if I could run, which I hate doing more than anything in this world, I could pretty much do anything else.
Can you swim?
I mean, I know how to swim.
Maybe
I haven't
you go
tried.
After the Navy SEALs, like they.
Yeah, right. Well, I went from literally not being able to put my socks and shoes on. My wife had to put them on for me every morning to instant relief.
It's it's hard to even just like sit on a toilet after spine surgery because it hurts.
So bad.
Yeah, but even before, you're an independent young man, and you have to have your wife put on your socks and shoes.
Yeah, after she.
I don't know if my wife would put on my socks and shoes. So she had to put on both
kids, and then me.
She probably would.
It's like having a third child.
Yeah, exactly
she might
right.
Consider it.
She's actually, she's the most relieved.
If it was something in for her.
Yeah, right.
If I put your socks and shoes on.
I think she was sick of hearing me complain about all the pain.
Yeah, it's just let you deal with it.
Right.
After you're married for a long time, you don't want your spouse to be in pain.
No, she's good. She took care of me. She was right there next to me in the hospital.
That's a good test of a.
That's a nice thing. They're there with you.
She was there. She took off from work, and
I've had some patients whose spouses were not as nice and kind, and they ended up splitting up afterwards.
Oh wow!
That's
because it's a tough recovery.
When it rains, it pours.
Well, that shouldn't be the reason.
No,
there must have been other problems.
I think that was the excuse that they gave.
Right.
Well,
I mean, some people nurse it for too long, get addicted to painkillers, and then they use it in a surgery.
That's actually very important that you said that because, that's one thing is that yes, you can easily get addicted, and there are people that are addicted to it after surgery. We try to minimize what we give them.
Right.
Well, I'll give you 30 tablets. That's not going to get you addicted. That kind of thing.
Right.
So.
Yeah, I mean, it happens. So I could see how it's a slippery slope, and if you don't have the right mindset, I could see how it can ruin a marriage.
Because it's very easy to reach for a pill.
Yeah, it's very easy to just want to lay in bed, reach for a pill, and next thing you know, you're addicted.
You're addicted. Where's my pills?
And then you're edgy. You're fighting with your significant other. It happens. I've seen it.
Yeah,
unfortunately.
Yeah, it's a big problem.
Yep.
Well, look, I mean, Gary. You were an inspiration, I think.
Well,
I'm going to say this is
Well, I'm not sure about that.
But I think you are. I mean, I think this is obviously the best case scenario we could ever ask for.
Well, great doctors.
And we really appreciate it, and we really appreciate you coming on today and talking about your experience and everything like that. And
I'm happy to help you guys.
Thank you for coming to trusting us with your care.
You're proof of picking the right patient.
Yeah, well, I picked the right doctor.
It's a good combination.
It's like a real bromance in here right now.
Oh God, it's just look at it. It's the Spine Bros.
Yep.
Spine Bros.
I just want to say that basically these types of operations, are very, they may seem like it's a simple cyst thing, but it's very tedious, and anything can happen unless. The important thing is to identify normal beyond the cyst. So when you have the normal, you can work really basically backwards to get rid of the pathology.
Well, it's funny thing is that, as an orthopedic spine surgeon, we always like neurosurgeons. And we always thought, brain surgery must be really the peak of all surgery.
Yeah, yeah.
I remember talking early on when we started first working together. I asked Dr. Sonstein, I said, what's harder, brain surgery or spine surgery? And his answer was 100% spine surgery. And I was kind of shocked. And I said, why? He said, well, when people go in for a brain operation, they expect to come out a vegetable. They don't. They
I don't know if these days that's the case.
Well, but it's not surprising if some does it. But in spine surgery, they expect perfection.
You know what is the difference? It's the brain is bigger. There's more room when you do brain surgery. You can actually touch the brain, thump the brain. I mean, there's the spine. You have very
spine is less forgiving,
little space, to work in, and
it's more dangerous.
There's more danger. Like in brain, fluid can come out all over the place, and it's okay. Whereas spine, you have no reserve for that sort of thing. So I think there's a big difference in my opinion, but you could talk to my partner, Dr. Brisman.
He may disagree.
He may disagree.
But that's your opinion.
That's okay.
Right.
But
that's all right.
But that's it's just a tribute to making the operation seem simple.
You want to basically feel like we want to be straightforward. We don't want to make it into an elaborate, crazy thing. We just want to do the straightforward thing and get rid of the pressure and make sure it's stable and get out of Dodge. That was what happened.
Yes,
so,
and do it safely and effectively and quickly.
So again, thank you very much for coming here today. And,
well, thank you both. I appreciate both of you.
We will enjoy seeing how you progress over time and. Basically, what am I supposed to say here? Oh, yes, please like us, subscribe, and share the Spine Bros podcast.
We want to go viral.
It's on Spotify, it's on YouTube, Apple Podcasts, and social media.
Very good. Well, thank you for having.
Oh, you're very welcome.
Appreciate it.
Gary.
It's great, Gary.
Happy to be here.